Good afternoon and welcome to this European Heart Journal Dialogue. The main topic of this dialogue today is the SECURE trial, a phase 3 study of a polypill strategy in secondary cardiovascular prevention. It was presented by Professor Valentin Fuster at the European Society of Cardiology Congress at the end of August and published in the New England Journal of Medicine. In this pivotal trial, treatment with a polypill containing aspirin, ramipril, and atorvastatin within 6 months after myocardial infarction resulted in a significantly lower risk of major adverse cardiovascular events than usual care. Together with Professor Fuster, we are joined by Professor Filippo Crea, the Editor-in-Chief of the European Heart Journal, and the associate editors of the journal, Professor Michelle O'Donoghue and Professor Giovanna Liuzzo. Now, it gives me great pleasure to introduce to you Professor Valentin Fuster. It doesn't need really any introduction, but because I know him, I've known him for the past 40 years, it gives me really a personal pleasure in doing so. Valentin is an MD graduate of the University of Barcelona, and then he continued his medical studies at the Mayo School of Medicine in Minnesota. And then from there, he moved to the Mount Sinai School of Medicine of the University of New York. He also had a 4-year interlude in Boston at the Brigham and Women's Hospital and Harvard Medical School before returning to Mount Sinai, where he established the Cardiovascular Institute of Mount Sinai and later became the physician-in-chief of the Mount Sinai Hospital, one of the most brilliant, academically innovative hospitals in New York. Valentin has had a phenomenal academic career. I remember meeting him in the early 80s. We were both attending a very interesting meeting, the clinical research meeting that usually took place in Washington, D.C. And we were discussing our common research interest in antiplatelet therapy. And he went on to become a star of cardiology. And what I admire of him is his intellectual independence. He doesn't go after fashions. He has his own view, and he has a very broad perspective on the different aspects of cardiovascular disease, pathophysiology, cardiovascular disease prevention, and not just the conventional type of prevention that we are used to, but also what he calls primordial prevention, which I think is the thing of the future. Well, I don't want to take any more time. He has received all the best awards that you can think of, including one that I'm honored to have shared with him and with Gareth Fitzgerald, that is the Grand Prix Scientifique of the Institut de France. But he has been awarded gold medals by all the major cardiological societies. So, Valentin, it's really a great personal pleasure to discuss with you about the SECURE trial and hopefully about your common research interest. And I would like to ask you to give a 5-minute introduction to the rationale behind the trial, the problem you have encountered in launching this European trial, and then we will turn to Michelle and Giovanna for digging into mechanistic questions.
Thank you very much, Carlo, for this nice introduction. I will say that over the last 10 years, I have been much more involved in understanding health than in understanding disease. knowing that better understanding of what keeps us healthy probably will have better tools in the future to prevent the disease and so forth. So I'm saying this because the story of the polypill began 15 years ago when I was still working on trying to understand disease and prevent disease in itself, but on a secondary prevention role. This is the story. I was working on a trial. This was the Freedom trial on diabetic patients with cardiovascular disease and multivessel disease. And what it became quite exciting about the trial is, yes, we found that patients with multivessel disease, the use of CABG was superior to the use of stenting. But about a few months later, I began to see the results of how much medication people were taking. And the results were absolutely dramatic. Only 25% of people in the Freedom trial actually were taking the appropriate medications that we used to take, that we are supposed to take in patients with coronary artery disease. So it came to my mind what to do. And I said, the problem most likely is too many pills. We have to go for simplicity. And this is how the concept of the polypill started. I went to a number of companies in the United States who said, this is very interesting, but we are not interested. The reason was because they had experience with HIV and the use of polypill, which became really a very financial burden to a number of pharmacological groups. So I finally found a friend, socially oriented, says, you know, if we can go to developing countries, we'll have a polypill that at the same time will be much cheaper, and let's work together. And this was Laboratories Ferrer in Spain, the CEO. We decided to take the chart together about 15 years ago. The story is not easy because we had to develop 50 polypills in order to address patients with myocardial infarction. And that is, when you put pills together, it's very complex because their pharmacokinetics change compared with the pills being taken separately. Just to give you an idea, the cost of the first polypill, aspirin, simvastatin, and ramipril, was 25 million euros, the cost, in order to reach a polypill that would satisfy the appropriate agencies. Well, this led to the FOCUS study of 7 countries in which we tested a polypill, aspirin, this was simvastatin, and ramipril, compared with the pills taken liberally by the patients as usual, common therapy. And these were 2,000 individuals with myocardial infarction that were randomized into the polypill and the pills taken separately as usual. This was the FOCUS study, and the results were very significant, showing that adherence to the polypill was very significant compared with the adherence to the pills taken separately as usual. And actually, this particular study was presenting to us the hypothesis of simplicity. Then we had a study that we did with an insurance company in the United States, Aetna, 14,000 patients who actually had myocardial infarction. We found that those who were adherent to the medications according to the search in the pharmacies, in the prescriptions, did much better than those that didn't. So, but this was a retrospective approach to adherence, but we needed to have a prospective approach, and this is where the SECURE trial actually came in. The company that we started working with were not too happy in starting a trial. It was so costly with the first 3 pills I mentioned, but we decided to go ahead because I was funded by the European Commission. And this time the polypill was the same except the use of atorvastatin. 2,500 patients with myocardial infarction over age of 65 years. And these patients were randomized into the polypill 100 milligrams of aspirin, and then the atorvastatin maximum 40 milligrams, not 80 milligrams, and finally the ramipril, the use of 10 milligrams daily, but starting with 2.5 every 10 days, moving towards the higher dose. Most of the people who took the polypill, they were taking this at the highest dose mentioned. And then these were compared with the other group that were treated conventionally. Now, we did a primary endpoint, stroke and myocardial infarction and cardiovascular death. And this was also together with the use of revascularization. And this was primary endpoint. And the secondary endpoint was the same except revascularization. The average follow-up was actually about 3.5 years. And the types of details of the study can be discussed in a moment. But basically what we found is that there was a significant decrease in the primary endpoint in the patients treated with the polypill compared with those who were treated conventionally. And the results were, for example, cardiovascular mortality decreased by 33%, relative reduction. And then in the secondary secondary endpoints, even the results were more significant. I think what was a critical issue in the study was the fact that 16 predefined groups all showed exactly the same trend in favor of the polypill, in a way giving you validity to the study or to the results of the study. These were the pre-specified approaches. The question is how this works. We look at addition, and certainly it was a significant better adherence to the medication in the polypill group than in the non-polypill group. Although we have to say that the total, the results of the adherence alone could not explain totally the significant results that we found comparing both types of approaches. Then we look at adherence certainly was significant. And then we look at what can be different biologically. You cannot say whether aspirin work or not. We didn't have endpoints for that, specifically for aspirin. Ramipril, the dose given, actually, it doesn't decrease significantly blood pressure, as is very well pointed out in the literature. And what was fascinating to us, or at least a curiosity, LDL was exactly the same in both groups. Something that we found in the FOCUS original study, no change in LDL. And we can present in a moment what is our hypothesis of what might be going on. So at the very end, we concluded that the polypill certainly had a significant improvement in cardiovascular events in patients with acute myocardial infarction, which at the beginning we said, well, 6 months for the entry is fine, but actually the entry into the study ended up being much earlier, like a couple of weeks following myocardial infarction. I say this for the following, because the curves began to separate from the very beginning. And what most exciting is that at 4 years, the curves continue to be separating. So I don't know if the study had been prolonged longer, the results would have been even as significant as I mentioned. The events, cardiovascular events or side effects were very similar between both groups. And we basically concluded that the polypill in patients with myocardial infarction over age of 65 years was of significant benefit compared with the pills actually taken separately. One limitation in the study is that the COVID came in and 14% of the patients stopped the follow-up at the time of COVID. So we took the follow-up to the last follow-up before COVID took place, 14% of the patients. And these are basically the results of the study.
Thank you, Valentin. Okay, I'll ask Michelle to start questioning Valentin Fuster about the overall philosophy of the study. Michelle has a distinguished chair in cardiology within the cardiovascular division of the Brigham and Women's Hospital in Boston. Michelle.
Thank you, Carlo, and thank you, Dr. Fuster. I think no doubt there will be a lot of questions that come up as we think about these interesting results. And I know Giovanna will be following up. But as Carlo said, we wanted to ask initially just a broader question, perhaps. So there's been a lot of talk these days about moving towards an era of more personalized medicine. And thinking about the unique individual, what therapeutic strategy might be best for them. And then at the opposite end of the spectrum, we have the polypill, which is in essence the opposite of a personalized strategy, but offers the advantages that you touched upon in terms of simplicity, being able to take one pill rather than many, and then therefore contributing possibly to adherence. So who do you envision eventually as being the recipient of the poly pill? You had mentioned developing nations. Is that who you envision, or would there be a role in Western populations as well?
Well, first of all, there is no exclusive approach like personalized medicine and generalized non-personalized medicine. I can give you examples. I mean, if we are talking about coronary artery disease, and I tell you that at least 75% of people are not taking the pills at the appropriate dose, I cannot talk about personalized medicine. Are we going to give a different statin to this patient or different, when in fact the problem is simplicity, I would say, could be one of the hypotheses in being the answer. The same happens with heart failure. I can tell you, I have been approached in the last few weeks by so many people in the heart failure discussion, and they say, we have at least 4 or 5 agents and one every day. Should we have a polypill in heart failure? And this is general issues. It's not even personalized medicine. I think if you talk about disease entities, genetic disorders or amyloid disease, specific disorders that require a specific treatment, as it has happened in the area of cancer, obviously personalized medicine is important. But to me, at this moment, we have a huge issue. And the issue is cardiovascular disease is beginning to climb again, going up. And so cardiovascular mortality. So be sure that when we talk about personalized medicine, we know what we are talking about, and we don't get away from the fact that the main problem is still people not taking the pills that are supposed to be given according to the guidelines. The next question that you have is who or where. First of all, we started this in a way thinking the polypill would be better because of simplicity, and we could go to countries that actually the polypill would be much cheaper. We already have the data and will be published soon about cost effectiveness. And certainly there's no question that the polypill is cheaper and is a better effectiveness. So I think we might be able to go to any country with a type of a medication that is very simple, easy to take, following the guidelines, and at least fulfilling what we now is a problem. In low economy countries, Yusuf published this not too long ago, only 7% of people following myocardial infarction are actually following the medications they're supposed to. So I'm presenting to you the realities. This should be for everywhere, for everybody. And at the same time, let's not be sure that we dilute the issue by talking about personalized medicine, which is very important in a number of disease entities.
Thank you. Giovanna, did you want to ask the next question?
Yes.
Giovanna, let me say a few words about Giovanna Liuzzo. Giovanna is professor of cardiology at the Catholic University School of Medicine in Rome, Italy. And she has had a long-standing interest on the role of inflammation in acute coronary syndromes. Giovanna.
Thank you, Carlo. Actually, it's a great pleasure to have the opportunity to ask some question to Dr. Fuster about this relevant topic. I was really fascinating from the SECURE trial, but also in general for the topic of the polypill. And it's great to have the possibility to ask a couple of questions about the potential mechanisms underlying the remarkable superiority of the polypill versus usual care in the SECURE trial, actually. You said before that the benefit of the polypill may be related to the higher patient compliance with the polypill as compared with the usual care. But also you said that LDL cholesterol and blood pressure control were identical in the two arms. So my question is, what are the mechanisms? What is your hypothesis? Another thing that you said that was really interesting to me, that it's not that easy to find the right thermodynamics for the drugs put together in the polypill. Because I had an hypothesis, maybe a very, strange hypothesis, that is also the fact that the medications are together and are taken together by the patient. They change something. They make their effect more favorable than if you take the single drugs alone. And this is apart from the adherence. Is something more. There is the adherence, and then there is something more, because your data show that the effects of the polypill goes really higher than the adherence by itself. What you can say about?
Yeah, we found this in the focus study too, and we had a discussion about it. But as you know, let me give you, in my view, there are three possibilities here. The first possibility, as pointed out so many times, Dr. Brown, Will Levy, and others, and that is when we talk about the statins, this is not all cholesterol lowering. This antithrombotic effect of statins, and actually there is already data in the literature on statins being given and preventing cardiovascular events very early after myocardial infarction. So the possibility of statins being antithrombotic, number one, or anti-inflammatory, number two, is something that we were not able to measure, and may be very important following acute coronary syndromes. Second possibility is that the dose of atorvastatin by the group that were taking the drugs freely was higher. In fact, 2/3 were using 80 milligrams of atorvastatin, where after we consulted with EMA in Europe and with the FDA in the United States, they told us that following myocardial infarction was appropriate to use 40 milligrams of atorvastatin as the maximal dose. So this may be a difference. And the third possibility is that we don't know. In other words, maybe statins are not playing a role. I think they do by the mechanisms that I mentioned before, but this is perhaps a very superficial and biased view. But certainly the LDL cholesterol was the same, I have to say. And with the curiosity is the same we found in the, again, in the focus study. So very simple. So maybe we are also approaching risk factors that perhaps we don't pay attention to, but I still would go into the anti-inflammatory effect and the antithrombotic effect of statins. This is as far as I can tell you. But one thing that you are absolutely correct, adherence alone did not explain all the results. Certainly in great part of it, but still there is some there that is not explained by just the data on adherence.
Valentin, if I can add something on the mechanistic aspect of the study. These were patients who were recruited within 8 days on average from the index event. And if I look at the Kaplan-Meier, particularly for the key secondary outcome, which is, as you say, myocardial infarction, stroke, and death, they separate pretty early. Now, I cannot think of a statin effect or a blood pressure lowering effect having such an early impact. But these were patients who not only received aspirin in the polypill, but also a P2Y12 blocker outside of the polypill. So can improve adherence to the polypill bring with it increased adherence to, for example, the P2Y12 blocker component of dual antiplatelet therapy. I mean, in the acute or post-acute setting, the efficacy of dual antiplatelet therapy is pretty substantial. So what do you think about this?
Yeah, quite in agreement with you. Is a possibility that you are selecting a population that actually begins to do the right things, other than the way we are defining adherence by the more risky approach. And this is very possible. We have data in the FOCUS study, for example, that adherence had a lot to do with depression. And that is, the adherence was significantly decreased in people who had depression following myocardial infarction, while in fact the adherence was increased in those who had a much more positive view of life and so forth. So there are a number of issues that are around the adherence that we were not able to quantify, and some you already mentioned. It is possible that we are dealing with a population that adherence is even increased further by other mechanisms.
Giovanna?
I think that the questions that are being raised in this discussion are so interesting, right? And I'm sure many people on the line are having the same thoughts. Because Dr. Fuster, the question of the pleiotropic effects of statins, is such an important point. And at the same time, I would have expected that if there were pleiotropic effects that were being seen with these therapies due to greater adherence, would we still see a lower LDL cholesterol? Because I normally expect that the two go very much hand in hand. Is there any reason to think that the people who were coming in to have their LDL cholesterol measured were in some way different between groups, so that we're spending too much time focusing on a measurement that for some reason was perhaps not a reliable surrogate of adherence?
Actually, this is in our discussion of the paper, because we are talking about the measurement being done in 80% or 79–80% of people, but not in the totality. And the other issue that I think is important, trying to go along with questions that come to our minds, is that the adherence, for example, was not measured, let's say 30 months later or 40 months later. So we did it rather in the earlier stages, and maybe there are differences afterwards. So there are many questions in this regard, and I agree with you. What you're saying is that in a way, in one way or another, we are selecting the patients who are going to do better. And there are many possibilities here. And I don't disagree with your comment.
Massimo Volpe. Massimo is also a member of the weekly Journal Scan team at the European Heart Journal, and he's a professor of cardiology at the State University of Rome, La Sapienza. Massimo.
Yeah, first of all, it's great to meet you, Valentin, tonight. And we had a lot of discussion in our team about the mechanisms of this spectacular difference between the polypill and the control group, and we were focused on the mechanisms basically, and there are two of the three components of the polypill that you cannot really measure. So let's assume that there was no difference in LDL for whatever reason, because the control group was taking statins anyway. Maybe they were not so adherent, but they did. But for aspirin and ACE inhibitors, I think it's difficult to say. And I tend to think that a simplified therapy which favors adherence and in which you take the ACE inhibitor every day, and that's for sure can help in better cardiovascular outcomes, or aspirin for the same reason, beside the blood pressure lowering effect of ramipril, which may be trivial in post-myocardial infarction, then I think we could sort of stick or make a reason to explain this difference. And personally, I'm very much in favor of the polypill, because people who take who have a myocardial infarction, then they take a lot of medicines. So it's probably, if you can put the three fundamental together, it's very important step.
Well, obviously I like your comment because it gives us an explanation, and that is we have two agents here that are very powerful. I mean, who doubts about aspirin, and certainly who doubts about the ACE inhibitors in terms of vascular health is complicated how they work, but that's a different issue. And these may be sufficient to explain. I'd like to make a couple of comments here, and that is what was very striking to us is the fact of the separation of the curves being so early. And I think Carlo alluded to this, and that is there is maybe some clue there. And then the other aspect that was also very interesting, and Stuart Pocock was actually very strict about it, but we have data up to 5 years, and the curves continue to separate significantly than what was presented in the figures in the journal. So, but I think this early departure to us may have some clue there. The second aspect that I want to comment on is the aspect of primary prevention in the polypill. The only reason I'm mentioning this is because we are all using pills that guidelines tell us to use. This is what secondary prevention, the advantage we have, we must do it. Mm-hmm. So no more thinking. For primary prevention, the situation is much more complex, because what kind of a polypill we might use for primary prevention? Are we going to exclude aspirin unless the patient is in a very high risk, and so forth? So I just like to convey to you my present state about the polypill, and that is simplicity in the results that we have seen, and as the curves separate, and as 16 pre-specified groups all move in the same direction. I can only say to you, I cannot tell you about the mechanism, but at least it gives me confidence that this is a real result. I mean, this is a real a type of thing that can have implications in the treatment of patients in the future. Then we can discuss in more detail patients with a stroke and so forth. But I wanted to get very quickly the issue of primary versus secondary prevention, because if you go back to history, the polypill has been an issue for primary prevention. Mm-hmm. In fact, I even was afraid to talk about the polypill over all these years, because it seemed I was out of line to the real discussion, which was the polypill used for people for primary prevention. And I like to say today that there is no other study that I know for secondary prevention that the polypill provides results that at least are quite hopeful.
I see more raised hands. Eloisa Arbustini, who is a professor of pathology. Eloisa.
Eloisa, nice to see you.
Nice to see you, Dr. Fuster. My question is simple.
Can you try to speak louder, Eloisa?
Yes, let's try. Can you hear me now?
A bit louder, Eloisa.
Or closer to the microphone, maybe.
I think we lost her.
Oh. I'm sorry.
Well, let's give the word to Dr. Song, who also has raised the hand. Dr. Song?
Hello.
Yes.
Nice to meet you. And first, let me introduce our party. We come from China, and a city of Ningbo is at the east of China, is a seaport city. And our city is the largest port in the world. And we are very honored to introduce, to participate in your discussion. And I believe you have, Professor Fuster, you have done a very great work. And I think we have learned a lot of knowledge about the long-term uncertainty of the polypill effects in the patient with infarction. And I have one question. How do you integrate? How do you integrate the hypertension patients, even they have hypertension, and how to you assess their effects if they have a very high blood pressure, and how do you balance the effect of the hypertension treatment and your heart benefit?
Can I ask you a question? I want to understand. Are you talking about whether patients who were taking the poly pill were hypertensive, and what did we do with them?
Yes. If
this is
they
a
have
question,
a very serious,
yeah. Well, no, look, these patients were treated aside of the poly pill. They had other treatments related to other issues that might be necessary, cardiac arrhythmias. It might have been blood pressure and so forth. The only thing we can say is when we look at all these possibilities and we compare the poly pill group and the group that took the conventional drugs, we didn't see much difference in terms of extra medications being used for specific entities. In other words, we found the same number of patients, I would say hypertensive patients that require antihypertensive medication in the group conventionally treated than in the group that were actually using the poly pill. So when we talk about the poly pill, means agents that are necessary to be used, and then other agents may be important. I want to make a comment here, and it's about beta blockers. Beta blocker has been one of the primary drugs being actually considered for patients with myocardial infarction, but specifically in the most recent years have been patients with rather decreased ejection fraction. So we excluded such patients with significant decrease of ejection fraction. But we found another problem with beta blockers, and that is at the moment you put the beta blocker with the 3 pills that I mentioned, the pharmacokinetics significantly change. And actually, I'm talking about the ACE inhibitors, for example, and others. So we excluded beta blockers for 2 reasons. One is difficult to maintain the pharmacokinetics of the other 3 drugs properly. And second, the patients who are supposed to take beta blockers were patients who actually had a rather decrease in ejection fraction, which were not actually entered into the study.
Okay, Eloisa, back to you.
Can you hear me now?
Yes, very well.
Dr. Fuster, my question in fact was exactly on pharmacokinetics. And my question was about the pharmacokinetics of statins in polypills. Does the pharmacokinetics of atorva, for example, coincides in polypills with that we measure in patients who takes individual separate single pills?
I don't think I can give you an answer, Louise, about this question. But when we measure pharmacokinetics, this was the measurement in blood of the T2 actually half time in terms of the highest dose of the drugs that we were giving. And we are talking about the 10 milligrams of ramipril and the 40 milligrams of atorvastatin. And this is really one of the critical issues that is being looked at the FDA for the approval of the drug, and that is how is the half-time barriers. And this is the main actually aspect that we measure as such. There were other aspects that I don't feel competent to actually present to you that were also measured, but this was a critical one.
Carlo, can you add?
Giovanna, go ahead.
Actually, I would like to ask what is going on next? What you are doing next to, to bring the polypill into the treatment of patients after myocardial infarction?
Well, we already have the first polypill that I mentioned in the focus study approved in 34 countries. Now, this is the polypill that actually use simvastatin. The polypill that we are using now is the one that we are presenting to EMA again and to the FDA. Obviously, we have to go through a due process, and this is our next approach. Why? Because we think that if this polypill really is acceptable and the data is acceptable as being of significance as it appears to be, we would like this polypill to be available worldwide. So for patients with myocardial infarction. Now there are other questions that are evolving. And the first one is, what about patients with a stroke? We don't have data of that. And what about patients who are at a very, very high risk, but not necessarily with a cardiovascular event? We don't have data on that. So there are a number of questions that we have at the present time that we would like to be able to approach. But I think that if the polypill as such is being approved by the organizations I mentioned for patients with myocardial infarction, and the results, as I presented, are really what the significance of this polypill is, I think this has a significant impact. But there is more than that. We are now thinking differently with other disease entities. And I mentioned heart failure, for example. We all are facing patients with heart failure, and it's a very similar concept. We are talking about polypill means several pills that had several different actions. We are not talking about 3 antihypertensive medications here. So now we are getting into fields that the adherence is low, as we know in heart failure, for example. And the question is, should this be addressed? At least the thought should be there. But there's a final question. Should we have more trials than the SECURE trial in order to prove the data, which you always like to have 2 trials? Well, from our point of view, I would say, the results were so similar in the focus study. And the result was so close to what we found with the insurance company, the Aetna study, that to prove that adherence to medications is important and therefore to move forward a polypill, I'm not entirely sure I am so favorable to that. I am more favorable to say, let's move into general populations, myocardial infarction across the world, and let's move into entities like so prevalent like a stroke that we have already guidelines of what should be used. I see more that direction than the other direction, and even more than the primary prevention direction. This is the way I see the situation now.
Just another question, if I can. In the next study, even in a different population, like stroke or the primary prevention, do you think that having a more scientific proof for the adherence may be more, can help in the explanation of the mechanism? Like I'm thinking about the fact that in the SECURE, the people self-reported that they adherence, but we don't have you know, the number of the pills that were used and so on. What do you think about it?
You're so right, actually. When we talk about adherence, we become very humble by just how we define it. We can tell you in the focus study, we use 3 different approaches. And the Morisky approach is still the patient is answering the questions. And then we try to give a validation, and we give in a way, we make a statement if the adherence is low, middle, or high. But you know, it's very difficult to measure, but this goes to the bottom line of your question. As difficult as it is, should we be able to get more from it than what we know at the present time by using the Morisky approach? And this is something that I feel maybe, but the measurement of adherence is very difficult. And I tell you, we have done it even in the focus trial. We went to the pharmacies in terms of looking at the prescription and of the medications and so forth. And still, we didn't feel happy. So there is more to the adherence definition than what we have at the present time. Therefore, I go along with you. Maybe we should get more into it.
Thank you.
We are honored by the presence of Professor Peter Libby, Professor Eugene Brownwald among the participants. Any comments from either Peter or Eugene?
So,
Okay, there they.
Peter.
I yield to
Mute, Professor. Okay.
Brownwald.
Professor Brownwell,
Eugene,
it's unmuted.
yeah.
Yeah, can you hear me?
Yeah.
Yes, very well.
Okay. Well, I want to congratulate Dr. Fuster and the group. This is a very important paper, and I think it is going to affect clinical care substantially. I have a couple of questions. You looked and provided good information about many subgroups. The interquartile range of time after the MI was 3 days and 37 days. So a quarter of the population were very early.
Yeah.
And a quarter of the population were much later. And did they show the same things, Valentin?
Yeah, I should
groups?
look at the data, I think, but I think they do. Yeah.
Yeah. Well, that's very helpful. That strengthens the case, because otherwise you could see that the patients were quite different. Could you tell us a little more about the control group? Your paper says, you know, the standard treatment as discussed in the guidelines, but that first of all, how many visits, how many times did patients in the 2 groups visit the coordinating center or the physicians? Is it possible that since the trial was unblinded, it couldn't have been blinded, but that the number of visits and the attention that was paid to the patients in the polypill group was more intense than in the controls?
Well, very good question, my friend. I will tell you, there were 12 visits, and we were very, very obsessed about the question, that we didn't want to have any kind of bias in terms of every aspect of these patients.
Yeah.
Six of the visits were face-to-face. The 6 other visits were by phone, okay? But
Yeah.
that's how it was. And there was no real difference in terms of the number of visits or that we can tell. But there is an issue here that I would like to convey following your question. Why a trial like this followed through in the middle of COVID and with all the aspects of the complexity of motivating people to enter patients like that? And the answer is, we met every 2 weeks with all the investigators by phone at 5 in the morning, New York time. And I want to emphasize, because one of the issues was be sure that the visits are done perfectly in both groups well, and all the other aspects. But I want to point out something that sometimes maybe escaped from all the discussions, and that is what makes a trial successful. And again, I don't want to be arrogant here at all, but one thing I can tell you, the 7 countries had the 7 principal investigators that were online every Monday at 5 in the morning, New York time, and or 5:30. And we went over every detail that could actually present any bias in one way or another. And one of the aspects discussed was is actually your question. We feel at least comfortable that there was no bias on that, but you know, what can you say? The study, obviously, you don't know when the study is not completely blind in the way I'm presented.
Peter, you were about to say something.
Yeah, I have a brief comment and a question. First of all, regarding the time course of the so-called pleiotropic effects of statins, I think that there are data showing that you actually get improvements in endothelial vasodilator function quicker than you have a decrease in LDL, and it happens within a matter of days. So I think Ulrich Raus, who's now in Leipzig, published that result. My question is, Valentin, great to see you. And as usual, you're leading the pack with your innovations and your ability to organize and to inspire people. My question is, will the next iteration of the polypill and secondary prevention include low-dose colchicine?
First of all, you know my wishes to you personally. And having said this, Peter, you know, I am a little confused about the anti-inflammatory drugs, I have to tell you, because more than I learn about inflammatory pathways, more difficulties I have in knowing what is the right anti-inflammatory drug that could be successful. However, everybody talks about colchicine, and I think somebody actually brought this up to me very recently. Should we add colchicine to that? I think it's reasonable. I can only say to you, Peter, that to carry a trial like this is so complex or so difficult that somehow another trial would be perhaps then should be done, but I don't see. I see a lot of difficulties, I must say, Peter. And then the question I have for the next trial: what would you compare with? Would be a polypill with the pills separated? Again, when we have the data on a single polypill with the data available. So how would you design the new trial?
Yeah. I think that would be quite challenging, because to do factorial design sort of defeats the purpose of the polypill. I agree. But personally, I would be concerned about the colchicine because of some people will have impaired renal function, and we aren't sure about the safety in terms of susceptibility to infection. And of course, we might interfere with GI tolerability. So I might steer clear of colchicine, but I'm sure that it will come up.
Before I turn to Dr. Zhang, we had received a question prior to the dialogue from Dr. William Feeman at Ohio State University. Is Dr. Feeman on the line?
He is indeed. I don't know if he's available to pose the question himself. I've just unmuted you, Dr. Feeman, if you want to pose your question. If not, you might reiterate it, Carlo. Well,
he was making the point that polypill is unlikely to get us to an ideal LDL cholesterol goal. whereas titrated therapy using stronger statins and or non-statin regimen is likely to achieve this goal without unwanted side effects. What do you think?
Well, I would like to have more of in-depth of the question. I can only say to you that no patient of mine will go without a statin anyway. So
He's making a point of reaching a more aggressive threshold than can be achieved with a standard dose.
It may be one of the reasons for which we didn't go to 80 milligrams is because we thought that a significant population would have side effects. And in fact, when we started the trial, there was significant reluctance by a number of investigators to use 80 milligrams, despite of the data available in the literature. So we asked for advice and we went into 40. Maybe we made a mistake and the dose should be higher. I am not entirely sure about it, but we are more fixed at the moment into what Peter Levy mentioned, that the pleiotropic effect of these statins start very early, and we are still in that pathway rather than thinking in changing dose.
Dr. Zhang, a quick question.
Sure. And thank you, Dr. Fuster. So, and you already, at the very beginning, you mentioned you have more data regarding the cost effectiveness for the drug, for the poly pill. I think for the developing country, the cost of the guideline recommended treatment is the major barrier for the patient to get access to medication. For example, heart failure, we have many flooding agent, and we have a neprilysin inhibitor. It's a guideline-directed treatment, but cost is a major barrier for these people to get this medication. And in reality, many developing countries, as I know, the heart failure basic treatment, they still use digoxin, still their basic treatment. They cannot afford to other medication. So I would, like to know how much it's cost and what is the, is it affordable for the developing country for this poly pill or not? Yeah.
I can, at this moment, I don't like to present you information that is still, we have to validate, but we had two separate studies that they look at the cost. I can only say to you that the cost of the pills taken separately is significantly higher. I don't want to say like double. I don't want to say that yet, but certainly it is compared with the poly pill that we have available. And this data, we have two pieces of information in the same direction, and this data is going to be published very soon. This is all what I can say. But you are presenting to us something that really we all should be bothered about it. Can we accept that in a low economy country, only 7% to 10% of people can afford to take these drugs? And to me, you're presenting a huge issue here. We all talk about prevention, but how affordable it is. Anyway, I'm just presenting you the concept that we started a lot of our work with the poly pill began with this concept, but it still is an issue. It's very expensive.
Filippo, do you have an additional question?
Well, our dialogues are very interactive. They are dialogues, and as you can see, it's really a global dialogue from China to States. I have a question not for Valentin. Valentin, thank you for this wonderful hour, but for Professor Braunwald. Can we unmute Professor Braunwald, please?
Yeah.
Well, Jean, you are famous, among the other things, because you never make mistakes with your predictions. Now, do you predict that the poly pill will reach our guidelines, European and American guidelines? This is my question. What about your prediction?
yes, they will reach the guidelines, but not as a 1A. It will be probably a 2A in the next several years.
Thank you.
Thank you, Gene. Okay, well,
Valentin,
this is important.
Valentin, before we bring this to a close, can you spend 1 minute or 2 minutes to tell us about your current research interests outside the polyp, particularly in terms of understanding health?
Well, my lines of research are quite different in the discussion we had today. First of all, we are dividing the population in 3 different ages: birth to age 20, age 20 to age 60, and age 60 to 100. And in the third group, we have very fascinating technology of imaging that is measuring blood flow in the brain in people who have risk factors for large vessel disease, PET scanning the uptake of glucose of the brain, and cognitive function. And I can just summarize to you the information that we are obtaining is that when we talk about risk factors that we want to prevent because of large heart attacks and strokes, we don't realize the huge impact that these risk factors may have in cognitive function. And we have now data on senile dementia and beginning to have data in the progression of Alzheimer's. That's number one. Between age 20 and age 60, what we are doing is the PESA study, 4,000 people that we are following for 20 years with 3D ultrasound to address subclinical disease. And the findings are fascinating. I will tell you 2, just to summarize. What we call normal, like an LDL cholesterol of 100 in somebody who didn't have any cardiovascular event, is completely abnormal when you look at subclinical disease, when you need an LDL less than 60. That's one thing. Second, all the guidelines are after age of 40. What is your risk profile age 40? If you now look between age 20 and age 40, and in the abscissa, you have the timing, and in the ordinate, you have the fluctuations of LDL, of hemoglobin A1C, or of triglycerides, for example, or of blood pressure, you realize that that age, 20 to 40, is significantly critical into what is going to happen later on. And we work this together with the cardio group and with our own group on the PESA study. So what we consider normal today, if you believe on subclinical disease in the way we are measuring with 3D ultrasound, which will be completely automatized next year, then you will see what is abnormal at that stage. And finally, between age 0 and age 20, you might know we are dealing with 50,000 children around the world at this moment, all randomized studies in which we are, the hypothesis is that in between age 3 and 7 years, you capture everything you are being told because the number of centers in the brain is rather small. And you retain these, and this comes out later on. Remember, all of you, about the environment that you live at those ages, and you will realize how you are today, and you will begin to understand what I'm talking about. So what we are doing is we are looking first sustainability, and that is how many times after age 3 to 6 you have to reintervene, because you have to. And in my view, is every 4 or 5 years. In these children, is 60 hours of talking about health in 4 different modules over 6 months. And then the other issue is the environment. What we are finding is the school system is not sufficient for the 60 hours. You need a family. And therefore, we are now working very much into the issue of how critical is the environment in the health of the population. And to give you an example, in all the studies that we have done that I'm presenting to you right now, the control group did very well. You know why? Because the control group were in the same schools and in the same systems than the people who were intervened. And this is having a tremendous impact, pointing out the importance of the environment, where it's at work, where it's in the school, wherever it is. So we are moving from the individual to the environment in terms of education. So there are 3 different EHJs with 3 different projects. And frankly, I'm very excited about it, because this is, for example, in the PESA study between age 20 and 60, not only we are following these people with for subclinical disease with 3D ultrasound, but we are looking at everything. You know, we are looking at the issue of CHIP, for example. How important is the change in the mutations in the hematopoietic cells as a risk factor in the elderly? And we are looking at all the issue of omics and so forth. So we are very excited, but basically it's a change I made myself about 10 years ago, and trying to move from disease to health and trying to understand health and the defense mechanisms of health. And I think this polypill got behind because it started 15 years ago. So at least we got the data on secondary prevention, but it still is worth it. But I'm working in a different field.
Thank you very much, Valentin. It's 6:06 in Rome, and we have to close, unfortunately, this extremely interesting, exciting dialogue. And I'd like to thank Valentin Fuster, first of all, but also Giovanna, Michelle, Massimo, Peter, Eugene, and Filippo, and all the other people who have asked questions or made comments to Valentin Fuster. I wish we had another hour with you, Valentin, to continue this dialogue, but maybe on another occasion.
Just a quick closing remark. Thank you, Valentin. You have been the first one to be with our dialogues for a second time. So thank you for the time dedicated to our dialogues, which have been very successful. So far, we had more than 10,000 views and participation from the 6 continents. So it's a very successful experience, and it is nice to really speak together in our wonderful cardiological community. So thank you, Valentin, Carlo, Giovanna, Michelle, and Massimo, all of you. And just to announce that next dialogue will be, as usual, on Thursday, the last Thursday in November 24th at 15 CET. Thank you again for this wonderful hour.
Thank you to all of you. Thank you, Carlo, and to you, Filippo, particularly. Thanks to everybody. Thank you.
Thank you. Thank you, Valentin.